Thank you for all joining me, and delighted as we go through. If there are any, because this is supposed to be quite interactive, so if there are any questions, then please interrupt me as we're going through. But we're going to go through some updates from diabetes, and there's some.
Dr. Chahal, sorry to interrupt you. Could I just say, would it be better if people to text into the chat rather than interrupting?
Yeah,
Yeah, just
text
because
into this chat.
I've kept everyone muted because otherwise there's a lot of interference.
Yeah, great. Yeah, that's all fine. So we're going to talk about different ways to help your type 2 diabetes patients. So either through lifestyle interventions, medications, or some GI interventions, which we can talk about. But why this is so important is particularly in the UK, there are a lot of patients diagnosed with type 2 diabetes. So probably about 7 or 8% of the population in some parts of the UK will have type 2 diabetes on their practice books. And this costs the NHS, or if you're abroad, your healthcare system a lot of money, because a lot of the costs are done to prevent the complications of type 2 diabetes. And once your patient with diabetes gets their cardiovascular event or their renal event, let's say if they go on to dialysis, a lot of money is plugged in to try to prevent that patient from getting worsening complications. But this figure is quite astounding. There are a lot of patients not diagnosed with type 2 diabetes who come as the first presentation of diabetes in the hospital setting, or even in primary care when they have advanced disease, particularly if they've got arterial disease, renal disease, or retinal disease as well. But when you see a patient who's newly diagnosed with type 2 diabetes, one thing you may not fully appreciate is a lot of the beta cell function in the pancreas is already reduced. So we're always taught type 2 diabetes is insulin resistance, and a lot of insulin is being produced by the pancreas. But the actual function of the beta cells is not great by the time someone is picked up and diagnosed with type 2 diabetes. And there are a lot of therapies now which are used to try to prevent a decline in this beta cell function. Because really, your patient with type 2 diabetes, if they don't control their diabetes early on, will need medications, be it oral medications, and then eventually insulin therapy. But there are a lot of good studies now suggesting that if we really help with obesity in our patients with type 2 diabetes, that can really help with the glucose control. And for those of you who are practicing in the UK and England, the rates of obesity have been going up steadily, as similar to other parts of the world. And about 1 in 3 of us, 1 in 3 of us at the moment are obese, which is a BMI which is over 30. And about 1/3 of our children aged 10 are overweight or obese. So these are the individuals that are starting to come to my diabetes clinic at the age of 18 with high sugar levels, when in the past we would have said they had type 1 diabetes. They actually have type 2 diabetes because of the prevalence, increasing prevalence of obesity. And obesity is so important in your patients with type 2 diabetes because if your patient with diabetes has obesity, they're at risk of all of these obesity-associated illnesses. And I really encourage you, when you see a patient with type 2 diabetes who's overweight or obese, make sure they don't have sleep apnea. And I don't think we sort of hunt around for a lot of these illnesses in our type 2 diabetes patients, because sleep apnea can make the metabolic complications of diabetes worse, or vice versa. Obesity and diabetes can make sleep apnea worse as well. Your patients with diabetes and obesity are at risk of fatty liver disease. There are a whole host of cancers associated with weight in your diabetes patients. And then traditionally, we know diabetes can put patients at risk of ischemic heart disease, of stroke. Obesity in our diabetes patients can cause fertility problems both in men and women, and there's also musculoskeletal problems that can happen. So really, there are a lot of illnesses associated with weight in your type 2 diabetes patients. And the question you may ask is how much weight loss is needed to make a benefit in any of these comorbidities. And certainly from a glucose point of view, the metabolic point of view, we're looking at about 5% weight loss. That can actually put your patient in a better metabolic function. But in terms of other illnesses associated with type 2 diabetes and weight, if your patient has sleep apnea, you're looking for at least 10% weight loss. Similar if your patient's having problems with fertility. And then from a cardiovascular point of view, you're looking at least 15% weight loss in your patients. Now, that's easier said than done, but if your patient appreciates that they really need to aim for 10 to 15% weight loss from a cardiovascular point of view, that may encourage them to try to lose more weight than a lot of our type 2 diabetes patients do. But there is now good data from a lifestyle point of view that suggests if your patient with type 2 diabetes lost 15% of their weight, their type 2 diabetes, if they've had it for a short duration of time, which is less than 10 years, will go into type 2 diabetes remission. And this was first shown in the community by this study, which you probably know about. It's called the DIRECT study, where patients in practices in the north of England, in Newcastle, as well as in Scotland, were asked to go onto a very low calorie diet, less than 800 kilocalorie diet for a couple of months. And then food was reintroduced at a much lower calorie content for a 1 year period. And these patients, they had recent onset type 2 diabetes, and before the intervention, they were asked to come off all of their type 2 diabetes tablets and go onto a very low calorie diet. And what was quite amazing about this study was that near enough 50% of individuals went into type 2 diabetes remission. That's off their medications with normal glycemic control. And it was those individuals that had the more weight loss, up to 15% and more, that really achieved this type 2 diabetes remission. And about 25% of individuals, 24%, were able to lose 15 kilograms in weight. So I think if you've got a type 2 diabetes patient who's recently been diagnosed, less than 10 years, you really need to emphasize if they were to lose 15% of their weight, they are at a high likelihood of going into type 2 diabetes remission. Now, a lot of our patients unfortunately can't achieve that through lifestyle changes. So there are a lot of medications now in the field of type 2 diabetes that can be used to lower glucose control, but only a couple of these have good cardiovascular benefit as well as renal benefit on top of the glucose lowering effect. And one such class of agents you may be prescribing a lot are SGLT2 inhibitors. And there are now four. I've only shown you three here. These are the three common ones that work through these receptors called SGLT2 receptors. And these receptors are located in the proximal convoluted tubule of the nephron. So about 90% of your glucose is reabsorbed back into the circulation through these SGLT2 inhibitors. And these medications, they work on the proximal convoluted tubule to prevent the glucose from being reabsorbed back into the circulation, and the glucose is excreted out into the urine. And it's about 200 to 300 kilocalories being lost in the urine, which is about a Mars bar and a half a day. Not that they should eat the Mars bar and a half and this tablet, but it sort of gives you the quantity of glucose that is being lost into the urine. The other class of medications you're probably or hopefully using a lot of are GLP-1 agonists. So it's around about in the UK time 3:40. So you probably would have had something to eat at about 1, 2 o'clock. Um, and probably half an hour to an hour after eating, you should start feeling more full and satisfied with food. And that is primarily driven by this gut hormone called GLP-1. Well, our patients with diabetes, type 2 diabetes, have been found to lack this hormone, and GLP-1 is so important in appetite regulation, as well as glucose regulation and gastric effects as well. And our patients with type 2 diabetes, because they're lacking this GLP-1 hormone, can feel more hungry, they're not satisfied with eating, and also there is a glucose imbalance from a pancreatic point of view. So replacing this hormone can help with glucose control and weight. And agents have been used quite readily since 2006, 2007 to replace the GLP-1 hormone. And you may have remembered there were agents called exenatide, which was a twice daily injection in the form of Byetta. We've then progressed to a weekly GLP-1 called Bydureon, which is the extended release version. But nowadays we're using a lot of the human-based GLP-1 analogues, and I'm sure a lot of you used to use liraglutide. You may still use liraglutide in the form of Victoza, but we've got better agents. Dulaglutide is a weekly GLP-1 in the form of Trulicity, and we've got semaglutide, which is Ozempic, a weekly injectable form. These are all injections, subcutaneous injections, but quite recently, Novo Nordisk has also developed a oral agent of a GLP-1 semaglutide, which is called Rybelsus. And this is the only GLP-1 oral we've got at the moment that can be given as a tablet therapy. This is the injectable Ozempic. I use a lot of it in my practice. And that's primarily due to the studies that are published, the use of Ozempic in patients with type 2 diabetes. And this was mainly through the SUSTAIN study, which compared injectable semaglutide compared to other type 2 diabetes agents such as sitagliptin, exenatide, Lantus, and even dulaglutide. Now, this was a lower dose dulaglutide. We've now got Trulicity dulaglutide at a higher dose, 3 milligrams, as well as 4.5 milligrams. And probably the dulaglutide at a higher dose is similar to semaglutide at the 1 milligram dose. But throughout the SUSTAIN studies, semaglutide had a better HbA1c reduction. And also, the other reason I tend to use semaglutide is the weight side of things, because our patients with type 2 diabetes are really struggling with weight. And we do see that the use of this GLP-1 can really help with weight. So these patients here were losing over 7 or 8% of weight because their baseline weight was around about 90 kilograms. So they're losing about 7% of their weight, which is really meaningful from a metabolic point of view in these patients who are really struggling with weight loss, actually. Now, this is oral semaglutide Rybelsus. It's pretty easy to initiate. I'm sure a lot of you have used it, but we tend to give patients an oral tablet, 3 milligrams once a day for a month. And then we ask them then to go up to 7 milligrams once a day for a month. And if needed, after that, 14 milligrams once a day. The only difficulty with the tablet as compared to the once weekly injection of Ozempic semaglutide is that the tablet needs to be taken on an empty stomach every day, and patients are asked not to eat eat for at least 30 minutes thereafter, and no more than 120 mils of water or fluid within the first 30 minutes. And they have to do that every day. So it can sometimes get a bit difficult for them to do regularly, whereas the once weekly injection seems to be a bit more convenient for patients. I tend to reserve the oral GLP-1 if patients tell me they do not want a weekly injectable device. But with oral semaglutide Rybelsus, we're seeing similar results in HbA1c reduction, so it's a pretty good, oral agent to use in patients. Now, you may have patients who are on metformin therapy and they've tried other agents or have had side effects to metformin, and their glucose is still not well controlled. And in the past, you may have given them insulin at that time if their glucose is not at target. The problem with insulin is it's an anabolic hormone, so patients tend to gain weight on insulin. And this is typical of this patient who has had 10 years of type 2 diabetes on metformin, and because he couldn't have other oral agents or had side effects, he's been put onto glargine. He's still not a target in glucose, but he's sort of gained weight. And these individuals, they should probably go on to GLP-1 agonists even before you think about insulin therapy. And that was shown in the Duration 3 study. This was using the old Bydureon, the once weekly GLP-1, compared with Lantus, which is a basal insulin. And these were patients who were on metformin therapy and had another agent, GLP-1 or insulin, added in. And actually, with the Bydureon, the GLP-1, we're seeing better glucose control over time as compared to insulin, Lantus. But the most powerful thing is that no matter how high the glucose level is at presentation, if you choose the GLP-1, we're still getting much better HbA1c reductions as compared to Lantus. Now, obviously, if your patient is symptomatic with a very high glucose level and you need to bring that glucose level down quite quickly, then insulin would be the way forward. But a lot of your patients will probably be happily going around 10, 11, 12% and not really knowing about it. And so there is time to reduce that glucose. But the real benefit from using a GLP-1 is the weight side of things. Because if you start your patient on the GLP-1 at that stage, then that patient will lose weight. Whereas if you have to put them onto insulin therapy, then they will gain weight. And the difference is up to 4 kilograms. So a real substantial difference in weight. And if you choose a product that causes weight gain, your patients will not really be that happy. So both agents will reduce glucose, GLP-1 much longer than insulin. But if there's time to wait to get that glucose better, then your patient will probably be losing weight on that GLP-1 agonist. And also having less likelihood events of hypoglycemia. So again, this sort of supports the notion of trying to use that GLP-1 much earlier on in the course of type 2 diabetes. But combination therapy is really important, and I think diabetes is moving towards what the cardiologists do with cholesterol. The cardiologists are very aggressive at cholesterol treatment, and by using SGLT2 inhibitors and GLP-1 agonists together, that really maximizes the amount of glucose reduction in our patients. This is a study using Bydureon, the weekly GLP-1, and Forxiga, which is an SGLT2 inhibitor. And what was shown was the combination of using both agents together, which is this line here, resulted in the best HbA1c reduction compared to using each separately. And we also saw a similar result in the study with weight as well. So using both agents together quite early on is important. And I think in the field of type 2 diabetes, diabetologists, as well as family care doctors, GPs, have been reluctant to use agents quite quickly on this, something called clinical inertia, Well, we wait until the HbA1c goes above a certain point, maybe 9%, and then you add in another agent. Well, actually, straight after lifestyle and metformin therapy, if in a couple of months we're still not at target, we should be adding in another agent, an SGLT2 agent thereafter, and then a GLP-1, to try to get that patient to baseline as quickly as possible. So there are a lot of agents you can use in the field of type 2 diabetes, but again, as I've mentioned, only a couple of them have good cardiovascular benefit. Um, the ones to particularly highlight are the sulfonylureas. Some of you may be still using a lot of glycoside, or if you're abroad, glibenclamide or glimepiride. Certainly that will cause the glucose to come down, but there is no long-term good cardiovascular benefit of sulfonylureas. So you need to think about what are you trying to accomplish in your patient who is on a sulfonylurea. If it's for immediate reduction in glucose for symptomatic control, for example, if your patient is on prednisolone for COPD and the glucose goes up and you really want to bring it down quickly for for helping with infections or symptoms, then yes, there is a role for it. But longer term, there may not be as much a role as compared to other agents such as SGLT2 inhibitors or GLP-1 agonists. And that's mainly from the cardiovascular data that's coming out with these agents. So there is now a lot of emphasis amongst diabetologists using agents that have good cardiovascular and renal benefit. And this sort of came about because there was a drug called rosiglitazone that was taken off the market in around about 2008, 2009, because patients with type 2 diabetes on rosiglitazone were found to have increasing rates of cardiovascular events. So since then, the pharmaceutical company have plowed a lot of money into showing their drugs are safe for our patients with type 2 diabetes, but only a couple of them have now shown cardiovascular superiority outcome data. And if I go back to this one, some of you may still be using DPP-4 inhibitors quite readily, like saxagliptin, sitagliptin, alogliptin, or even linagliptin. Now, these gliptins that I'm showing you here, there is no cardiovascular superiority data. So they're safe in our type 2 diabetes patients. They will be weight neutral, but certainly they won't be causing substantial cardiovascular benefit. And one of the DPP-4 inhibitors, saxagliptin, was shown in patients with heart failure to actually cause some worsening of heart failure hospital admissions. So just be cautious of using saxagliptin in your patients with heart failure. But the SGLT2 inhibitors and some of the GLP-1 agonists have shown some cardiovascular outcome data. And in particular, empagliflozin, canagliflozin, and also I haven't shown you dapagliflozin, has got cardiovascular benefits in our patients with type 2 diabetes. In terms of liraglutide, there is good cardiovascular data from the LEADER trial. With semaglutide, we're waiting for some more longer term data on it, but the preliminary data shows it can potentially cause cardiovascular benefits in our patients. In terms of the renal outcome data, this is really driven by the SGLT2 inhibitors data. So as you know, our patients with type 2 diabetes are at high risk of worsening chronic kidney disease. And quite recently, so in 2019, the first SGLT2 inhibitor that reported benefit in patients from a renal endpoint was canagliflozin. And this was in the Credence study, and this looked at a large number of patients, about 4,000, who were given either 100 milligrams of canagliflozin or were given placebo therapy. And what was found was that in these patients, there was a improvement in renal outcomes in patients who were given this SGLT2 inhibitor. So certainly there is benefit from a renal point of view in these patients who are started on SGLT2 inhibitors. There's a reduction in the deterioration in chronic kidney disease. There is also a reduction in patients ending up on dialysis and dying from end-stage renal kidney disease. And the other two SGLT2s have also shown now renal benefits, so dapagliflozin as well as empagliflozin. And actually, the licensing of these agents are now at a much lower GFR than what was before, because the nephrologists are getting very excited about the use of SGLT2 inhibitors in patients with diabetes, which this data is, but also in patients without type 2 diabetes. So there is an intrinsic um, renal benefit in patients without type 2 diabetes. So a lot has really happened in the field of type 2 diabetes over the last 20 odd years. If I was given this talk back in the early 2000s, a lot of you would be using sulfonylureas, second line glycoside in your patients. But over time, we then had the introduction of DPP4 inhibitors and now GLP-1 agonists. But certainly more and more of you are using SGLT2 inhibitors. And in the UK, we've got something called the NICE guidelines, which you should really read up. The NICE type 2 diabetes guidelines, which were published about a year and a bit ago, which advocate SGLT2 inhibitors second line after metformin therapy in patients, particularly with high risk cardiovascular disease or chronic kidney disease or established cardiovascular events. And this sort of emphasizes the role of these agents in preventing cardiovascular and renal disease. But this is the agent I'm really keenly waiting for coming to the UK. It's called tirzepatide. This is a dual gut agent. It works on GLP-1, which is similar to your semaglutide as well as your dulaglutide. But it also works on another gut hormone called GIP, which also has a metabolic function as well. And this, at present, if you were in America, if your patient was in America, is FDA approved for patients with type 2 diabetes. And it should hopefully be coming to the UK sometime this year. Some of you, if any of you are abroad in the Middle East, tirzepatide is already available in some of the Middle Eastern countries. But this data here looked at the use of tirzepatide in patients with type 2 diabetes and compared it to the lower dose of semaglutide, 1 milligram. And this is the 1 milligram is actually the at present the dose we give in the UK up to for patients with type 2 diabetes. So Nadita said, is this a once daily injection? No, it's a once weekly injection. So it's a bit like the semaglutide or the Ozempic or the dulaglutide, the Trulicity. But this medication was studied in patients with semaglutide being the comparator. And you can see at the higher dose of tirzepatide, 15 milligrams, you're getting much better glucose control as compared to the 1 milligram of semaglutide Ozempic. But why I'm very excited, because I'm also a bariatric physician, is that these patients were getting over double the weight loss compared to the 1 milligram semaglutide if patients were on the higher dose of tirzepatide. So certainly from a metabolic point of view, once this is available, I think this would be the go-to agent if it's an injectable agent you're giving your patient If you're considering GLP-1, well, we should be considering dual agonist therapy, GLP-1 and GIP, with tirzepatide being the agent. Now, in terms of other medications that can be given to help with glucose control, there is one medication which is licensed for weight treatment. It's called Misimba, which is made up of two components you may give your patients. One is naltrexone for patients with opioid deficiency, opioid toxicity, and the other one is bupropion, which is given to stop patients smoking. Where the investigators, they combined both products together, and they found that these agents work through the reward pathways, the hypothalamus, which is involved in appetite regulation and energy balance. And they found that patients with type 2 diabetes who are given these agents can have some weight loss. You're probably looking at about 5% weight loss compared to 2% for placebo. So certainly not as much as the GLP-1s or the GLP-1s and GIP. But there is some modest reduction in glucose control as well. So an HbA1c reduction of 0.6%. So I suppose this could be another agent to think about if you're really struggling with your patients with type 2 diabetes. There are side effects. If your patients are on opioids, we shouldn't be using this. If your patient has severe resistant hypertension, then there is a contraindication. Or if your patient has a history of seizures, then we shouldn't be giving this agent. So that's another agent to be aware of. But there's also bariatric surgery. So you may be wondering why a endocrinologist is talking to you or giving you a slide about bariatric surgery. Well, this is a way for our patients with type 2 diabetes to go into remission if they've got a recent onset of type 2 diabetes, so within 10 years. And the better procedures, there's different procedures. There's 4 in total now. There's the gastric band, there's the sleeve gastrectomy, the Roux-en-Y gastric bypass, and also a relatively newer procedure called the one anastomosis gastric bypass. And we do find that the 2 different types of gastric bypass are the better metabolic agents to help with glucose reduction. But I would hope with the introduction of tirzepatide, that dual agonist, that actually less and less of your patients will probably go on to bariatric surgery, because tirzepatide does seem to have very good metabolic as well as weight benefits. But in terms of your obese patients, there are already agents that can be given to them to help with weight. So this is data published 2015 in patients without type 2 diabetes who were given a daily GLP-1 agent called liraglutide. You probably know it's in your diabetes patients as Victoza, but that's a higher dose. It can be given in the form of Saxenda, which is a daily GLP-1 agonist to help with weight. And patients were losing about 7 or 8% of weight, but there was about 20% of patients compared to placebo who were losing greater than 10% of weight, and about 11% of patients compared to placebo who were losing greater than 15% of weight. So this is where the thought of using GLP-1s as a treatment for weight came out. This is Victoza, the lower dose liraglutide goes up to 1.8 milligrams, and we've got the higher dose liraglutide 3 milligrams, which is available for obesity treatment in patients with or without type 2 diabetes. But going back to semaglutide, there is now good data on the higher dose of semaglutide. This is up to 2.4 milligrams throughout the day, really helping with our patients with obesity who do not have type 2 diabetes. And in this study that it was published about 2 years ago, it was found that patients on average were losing 15% of weight at around about 6 to 9 months down the line. And what was really powerful was a third of patients who are losing over 20% of weight. Now, your patients who may undergo bariatric surgery, they will probably lose 20 to 30% of their weight if they underwent the Roux-en-Y gastric bypass, or the sleeve, or the one anastomosis gastric bypass. Well, if they go onto this GLP-1 agonist, semaglutide, at the higher dose, and they're responding in the third of patients getting over 20% weight loss, then that's really in bariatric surgery territory. So really, really powerful agent. And this agent, it's semaglutide at the higher dose, so not Ozempic. Ozempic only goes up to 1 milligram, but the Wegovy pen device has semaglutide all the way up to 2.4 milligrams. And this at the moment is available in the US, and we're eagerly awaiting for it to come to the UK, probably by summertime onwards. And this is probably the most powerful GLP-1 we've got to help with weight and glucose reduction. But when this agent, tirzepatide, again comes onto the market, well, there is also good data on the use of tirzepatide in patients without type 2 diabetes. And this was recently published middle of last year in the New England Journal of Medicine, where they looked at patients without type 2 diabetes who were obese, and they gave them the higher dose tirzepatide, and patients were losing on average 20% of their weight compared to 3% of placebo. So actually, this is probably going to be, once it is available for weight treatments, the most powerful dual gut hormone to really help with weight. And I think less and less of our patients will now be referred for bariatric surgery when they've got this this agent available. And that's my last slide. So I know I've done a lot of talking. I think there was one question, but happy to take your questions, and hopefully that's given you a good overview of what we have currently for type 2 diabetes, but I've also given you a flavour of things that are available for obesity therapy as well. So I'm just going to stop there, and happy to take any questions. Has anyone used semaglutide at all? Regarding use of tirzepatide Monjana, I'll just have a look here. What is the duration of use, or patients have to be on it indefinitely? So really good question. So one of your colleagues has asked, how long do you have to keep these agents for? Well, in the field of diabetes and obesity therapy, we strongly feel that both conditions are chronic conditions, and because it's replacing the gut hormone, we would say this is the long-term treatment. We are seeing, if patients, if you look at the graph, if they get to a plateau at about a year, if they do stop the agent, then they will get the weight and glucose getting higher over time again. So these are really longer term agents rather than shorter term agents. I'm just looking at Matthews. I think I missed Matthews. Sadly, none of these agents will be reaching the Caribbean any soon. So I'm so sorry about that, Matthew, but hopefully they will at some point, because from a cost perspective point of view, if you really bring down the glucose level, treat the obesity, a lot of these long-term complications won't occur, like cardiovascular disease, like kidney disease. And once your patient is on dialysis, they will cost the healthcare system a lot of money. And really, this goes back to how we should view medicine as a preventative thing rather than a reactive thing to once they get it, you see. I think Linda says more of liraglutide. So probably with the data I've shown you, Linda, semaglutide or tirzepatide has better clinical data in our patients. So the one thing with liraglutide is a daily injectable agent. So many patients prefer weekly injections rather than daily for convenience. But from a glucose and weight point of view, semaglutide or tirzepatide sort of helps more with weight and glucose. I think Sarja has said, I'm usually put my patients, but I have a question. Do we need to do pancreatic enzymes or thyroid? Yeah. So there are some contraindications to the use of GLP-1s. So one of the contraindications to think about is back in the late 1990s when GLP-1 agonists were being studied in animals, in rodents. Some of the rodents got a very rare type of thyroid cancer called medullary thyroid cancer. Now, we have never seen it in human type 2 diabetes patients who have been studied and have been on these agents now since the late 1990s. But one of the reasons is the rodent thyroid gland has receptors for GLP-1, whereas we don't. But for the unknown, if your patient has a family history of this very rare type of thyroid cancer called medullary thyroid cancer, or if your patient has established medullary thyroid cancer, we shouldn't give it to them for the unknown. The other situation is if you've got a patient who's got a history of pancreatitis, where there is a theoretical risk that GLP-1s may be causing pancreatitis. The jury's still out on that, but we don't routinely measure amylase levels. But I would be extremely cautious, and I wouldn't start it in a patient who's got a history of pancreatitis for the unknown. I think Saja said thyroid ultrasound. There's no need to do routine thyroid ultrasounds from these patients. Family history, personal history would be important because medullary thyroid cancer tends to happen at a very young age, and patients and families may have other endocrine disorders like pheochromocytoma, other genetic conditions associated with MEN2. But I would, in my clinical practice, just feel the thyroid gland just to make sure there's no obvious nodules at all. I think Linda said, but on BBC, semaglutide will be over the counter soon. I don't think at the moment in the UK there are plans to give it over the counter because patients still need to have a important clinical assessment. So as with a lot of medications like paracetamol, which you can get over the counter, you would still need an important medical assessment because there are some contraindications to GLP-1s, like that family history of medullary thyroid cancer, but also if the kidneys aren't working well, as is the case in a lot of our type 2 diabetes patients, if the EGFR is below 15, we shouldn't initiate semaglutide because it gets excreted through the kidneys. With liraglutide, it's below 30, we shouldn't be initiating it. We just need to be cautious. I think Saja says for how long we can use GLP-1s or we can stop them. So again, similar to what I answered earlier on, these agents we feel are longer term agents rather than shorter term. And there is clinical data now looking at GLP-1s over the last 20 years, which because the human studies would have been done in the late 1990s, not showing any unexpected side effects to these medications. Sorry, Linda, you said thank you regarding CI for GLP-1s. I presume that's contraindications. Yeah. Okay, good. Do you use a lot of SGLT2s at all? Well, hopefully you will, yeah. especially in cardiac failure. Yeah, Linda. So if you're ever getting talks from the cardiologists, they're very interested in using SGLT2s in patients with established heart failure. So both preserved and reduced ejection fraction. So there's lots of good data on that. And as I said, nephrology colleagues are starting to use it in patients without type 2 diabetes because there's good renal protection with these agents as well. Great. Does anyone have any other questions at all? Or has anyone referred anyone to bariatric surgery at all? Okay. Referred, okay, full sleeve, yeah. So actually, GLP-1 agonists can be used post-bariatric surgery as well. We do have patients who do not respond as well to bariatric surgery. And there is some data. There's one study from Imperial called the Gravitas study, GRAVITAS study, which looked at the use of the GLP-1 liraglutide in patients with type 2 diabetes who had previously undergone a Roux-en-Y gastric bypass, and showed that actually the GLP-1 can give some additional benefits from glucose and weight reduction as well, you see. How do you satisfy hunger when you're advised on a low-calorie diet? Yeah, it's really difficult. I mean, having more protein can help. Chicken, fish, eggs take out the yolk. I think Jay's mentioned protein water as well, so that goes back to protein making you feel more full. The problem with a lot of this thing is it's very difficult to sustain it long term, you see. And there are clearly patients who do not have appetite regulation. They feel hungry all the time. And this goes back to changes in this hormone GLP-1 agonist, because such as I'm sure you have a lot of patients on GLP-1s. If you hear a lot of these patients who responded well to it, a lot of patients tell us they feel it's like a switch going on, and they start feeling more full, more satisfied with food. And that's primarily how these agents work. They do it through appetite regulation, but there is also a metabolic component to these medications as well. Yeah. And I suppose after bariatric surgery, you just need to think about mineral replacement as well, because a lot of patients are on multivitamins for a long time. Whereas if patients underwent GLP-1 therapy and they respond very well, then they don't need to have long-term multivitamins or iron afterwards. Okay. If there's no other questions, then hopefully you've enjoyed the talk. As I say, a lot is changing in the field of type 2 diabetes, and it's mainly going to be driven by the use of these new dual agents, tirzepatide and Monjana. Has anyone prescribed it? Anyone abroad, maybe Middle East, who's had access to tirzepatide at all? If not, I mean, certainly in the UK, we're going to get it hopefully sometime this year. And as I was saying, this probably would be the go-to injectable agent. Yeah. Okay, great. So if no other questions, I think I'm happy to end it there. Right. See you later. Great.
Thank you.
Good. Shall I just log out or yeah?
Yes, you can do. I'll close the meeting shortly.
Great. All right. Thanks.
Thank you.
Bye.
Bye-bye.
Bye. Bye.